Thiazide diuretics derive from sulfonamide. They are the most commonly used diuretics. Being known as the low-ceiling diuretics, increasing doses of thiazides beyond the therapeutic dosage does not increase the diuretic effect. After this lecture, I wish to accomplish the following objectives. Thiazide diuretics target at the distal convoluted tubule of a nephron. At distal convoluted tubule, traffic of cations and ions moving between bloodstream and urinary filtrate is heavy. Diuretics that take effect here significantly affect the balance of electrolytes. Normally, sodium and chloride are reabsorbed via sodium chloride transporter. Calcium is also reabsorbed here. First, it enters the cell via calcium channels. Then, it is moved into the interstitial fluid via sodium-calcium exchanger. The movement of calcium is two-directional. When calcium is removed from the luminal fluid, it is also excreted back into the luminal filtrate. The movement of calcium here is regulated by parathyroid hormone. Thiazide diuretics affect both cortical region of the ascending loop of Henle and distal convoluted tubule, leading to series of cation movements between serum and luminal fluid. By inhibiting the sodium chloride cotransporter on the luminal membrane, thiazide diuretics decrease reabsorption of sodium. As a result, concentrations of sodium and chloride increase in the tubular fluid. Along with it, increases urine osmolarity. Thiazide diuretics also prevent reabsorption of potassium in ascending loop of Henle. Long-term use of thiazides leads to risk of hypokalemia. Monitoring potassium level periodically is needed when using thiazides. Abundant serum magnesium is excreted into luminal filtrate. Elderly clients are especially affected. While sodium, chloride, potassium, and magnesium are lost in the urine, calcium reabsorption is increased by parathyroid hormone here. Using thiazide diuretics help preserving calcium, which in turn preserves bone density and prevents fracture. The urine with hyperosmolarity continues its journey to collecting tubule and duct, where the tubular membrane is permeable to water. Subsequently, the water will not be reabsorbed but excreted into luminal filtrate in order to dilute the urine. Therefore, these movements of cation and ions lead to increased urine output, which in turn decreases the cardiac preload and blood pressure. One important side note here. Integrity of renal function is important to the effect of thiazide diuretics. Because medications in this group target at the luminal membrane, when the renal function is intact, these medications can be excreted through the membrane and take effect. If the renal function is impaired, thiazides cannot be successfully or completely excreted into the luminal fluid. The effectiveness will then be compromised. Therapeutically, thiazide diuretics belong to the category of diuretics. Chlorothiazide is the first orally active thiazide, whereas the newer agent, hydrochlorothiazide, is a much more potent diuretic. Thiazide diuretics are derivatives of sulfonamide. There are also agents called thiazide-like diuretics. Thiazide-like diuretics do not share the same chemical structure as thiazides, but they have the unsubstituted sulfonamide part. Their therapeutic mechanisms, functions, and adverse effects are then similar to that of thiazides. Thiazide diuretics promote uresis, decrease preload and blood pressure by affecting the movement of electrolytes in the nephron. The adverse effects are yielded from these medications' therapeutic mechanism and effects. Symptoms related to hypotension can affect both cardiovascular and central nervous systems, including orthostatic hypotension, dizziness, weakness, headache, etc. Side effects resulting from electrolyte imbalances affect metabolic equilibrium, including hypokalemia. Not only is hypokalemia the most common adverse effect, but also the major or even fatal side effect. This adverse effect could further induce drug-to-drug interactions. Hyponatremia, hypochloremia, and dehydration contribute to both compromised cardiovascular and neurological functions. On the other hand, thiazides can lead to hypercalcemia, hyperuricemia, and possible gout. The thiazide-induced hyperglycemia warrant blood sugar intolerance and imbalance. Being a sulfonamide derivative, there is a risk of hypersensitivity or anaphylactic reaction. Teach patients the signs and symptoms as well as management of these adverse effects. Patients should report to the physician if experiencing any side effect. Call 911 if experiencing any anaphylactic symptom. Just like any antihypertensive medication, when the patient is using a thiazide diuretic, blood pressure and heart rate should be monitored prior to administering every dose of medication. The adverse effect of hypotension should not be neglected. Patient education should include prevention of orthostatic hypotension and other safety measures to avoid harm should the symptoms affect central nervous system. Nevertheless, electrolyte and metabolic imbalances, including hypokalemia, hyponatremia, hypercalcemia, hyperuricemia, and gout, warrant a thorough patient history intake and periodical evaluation of metabolic status. Various drug-to-drug interactions and risk factor evaluation should be taken into consideration when providing nursing care in order to prevent eventful incidents. Patient factors, such as dietary intake and usage of other medications, can contribute to further development of preventable incidents. Hyperglycemia can be induced using thiazides because thiazide diuretics reduce insulin secretion. Monitoring and managing both blood sugar and dietary intake are important to prevent and manage this adverse effect. To avoid GI irritation, take medication with food. Thiazide diuretics are indicated in various cardiovascular and metabolic disorders, including hypertension, heart failure, hypercalciuria, and diabetes insipidus. Hypertension. Thiazides are affordable, convenient, and well-tolerated agents for managing mild to moderate essential hypertension. Daily dose can reduce peripheral resistance and not causing major diuresis. Heart failure. Thiazides are commonly added to loop diuretics for managing heart failure because thiazides reduce extracellular fluid. When used together, thiazides should be used 30 minutes before loop diuretics. Hypercalciuria. Thiazide diuretics are used to treat calcium oxalate stone in urinary tract because they reduce excretion of calcium into the luminal fluid. Diabetes insipidus. Usage of thiazides leads to urine with hyperosmolarity. Therefore, thiazide diuretics can be used to replace antidiuretic hormone for treating diabetes insipidus caused by kidney impairment. Let's recall one important note of thiazide. It is mentioned earlier in this lecture that thiazides are excreted through luminal membrane into luminal filtrate to take effect. This means that an intact renal function is vital to the effectiveness of medications from this group. Contraindications of thiazides include the following: anuria, hypersensitivity to thiazides or sulfonamide derivatives. Know that thiazide can exacerbate or activate systemic lupus. Thiazide should be used with caution for the following patients: children, patients with severe renal disease, or impaired or progressive hepatic disease. For pregnancy, lactation, and reproduction labeling, thiazide diuretics can cross through placenta and adversely affect fetus. However, if the patient has been using thiazide before pregnancy, the medication can be continued during gestation. If the patient decides to breastfeed, the medication should be discontinued after consulting the physician. Nursing care tailoring to contraindications includes patient educations on reporting to the physician if being pregnant or decision of breastfeeding. Healthcare personnel should collect thorough medical history, mild drug allergy. Using thiazides with amphotericin B and corticosteroids increases risk of hypokalemia. Thiazide diuretics can offset the effect of anti-diabetic agents when they are used together. There will be additive effects when thiazides are used with an antihypertensive. If used with opioids or barbiturates, risk of orthostatic hypotension increases. Loop diuretics are very potent. When using loop diuretics with thiazides, electrolytes and fluid status can be significantly affected. Thiazide-induced hypokalemia increases risk for digoxin toxicity and ventricular dysrhythmias when a thiazide is used with a cardiac glycoside. Cholestyramine decreases absorption of thiazides in GI system. Thiazides interrupt excretion of lithium, increasing risk of lithium toxicity. NSAIDs increase risk of renal failure. Nursing care for drug-to-drug interactions includes the following. Make a list of medication. Monitor status of electrolytes and fluid, renal function, as well as blood pressure and heart rate, especially when the patient is taking thiazides with diuretics, NSAIDs, antihypertensives, opioids, or barbiturates. Monitor blood sugar and adjust dosage of anti-diabetic agent accordingly when using both thiazide and antidiabetics. Take cholestyramine and thiazides 2 hours apart to avoid interruption of GI absorption of thiazide. Monitor drug levels of digoxin and lithium and monitor for drug toxicity. Licorice increases risk of hypokalemia. Alcohol increases risk of orthostatic hypotension and side effects of central nervous system. Nursing care for drug-to-herb and drug-to-food interactions includes the following. Teach the patients these interactions between thiazides and food or herbs. Instruct the patient to avoid taking either licorice or alcohol while on thiazide treatment. Thiazide is taken orally. It takes 1 to 3 weeks to establish a stable effect in reducing blood pressure. Both chlorothiazide and hydrochlorothiazide are thiazide diuretics. There are also thiazide-like diuretics, including chlorthalidone, indapamide, and metolazone. With a longer duration of action, chlorthalidone can be taken 1 dose a day. It is indicated for hypertension. Metolazone has a higher potency than thiazides. Therefore, it can induce sodium excretion on patients with advanced renal failure. Indapamide is lipid-soluble and has a long duration of action. It produces a significant antihypertensive effect with minimal diuresis at low dose. Being metabolized and excreted via GI and urological routes, indapamide does not seem to accumulate in patients with renal failure. Both metolazone and indapamide can be used in patients with renal failure. Thank you for spending time with me. I look forward to study with you soon.